Now I would like to request Dr. Kamaljeet Singh to present his talk. As you know, he is a chief instructor of this particular course, and has a lot of experience in doing SICS in most of the difficult, I can say, all kind of cases, and simplified. He has simplified the technique as well. As you know, along with we are sitting with Dr. T.P. Lahane. He has performed, highest surgery till date. Is doing the SICS and doing so many camps, organizing rural area, urban area, suburban area. So, and Dr. Kamal is also this prize, this particular the technique that SICS is still. Yes, Kamal.
Thank you, Professor. So we first of all welcome Professor Lahane and Dr. Professor Ragni Parekh in this important session. And SICS, as you all know, is a faster surgery. It's very cheap. And last time in Kumbh Mela, we had this kind of picture. And these are the kind of patients who come to our hospital for SICS or maybe cataract surgery. They don't know which surgery we would be doing. And they are ever thankful. Whatever you do, whether you do SICS, whether you do phacoemulsification or conventional ECG, IOL, they are immensely thankful. So we still do almost 80% cases in Allahabad and do SICS. So it's always said that if you serve the poor, you will be remembered forever. And sometimes we do SICS and can be done through very small incision. I'm just touching a little bit about the modification that we do in SICS. So this is a hypermature cataract, you can see. And in this, doing capsulorhexis is difficult. I usually use a forceps to do capsulorhexis, and a large capsulorhexis is usually required in SICS, whereas in phacoemulsification you just do 5.25, 5.5 millimeter. Here you have to remove, take out the nucleus out of the bag, so you need a larger capsulorhexis. So do a larger capsulorhexis, and then you simply aspirate the cortical matter and little bit of epinucleus that is there. In such big lenses, you have lots of this cortical matter, and the nucleus becomes small, and then you just increase it a little bit, and then you rotate it as Dr. S.P. Singh has also shown you, and Dr. Sharma has also shown, and you can just bisect it, and you can remove through a smaller incision. This nucleus can be easily removed, and make it vertical, the pieces that are there, and can simply remove them and implant the lens. Then you can use limbal relaxing incisions, which are very good to prevent astigmatism and correct astigmatism, and correct that astigmatism that you create. Surgically induced astigmatism many a times causes problem. When we do SICS, it causes 1.5 diopter of flattening. So you can do a limbal relaxing incision on the side. This is the frown incision that is given, and here at this end, just have a look at this point. At this place on the around 90 degree to the incision that we have made, you see just 6 millimeters, and 600 micron incision can be given on the limbus, and this corrects whatever astigmatism you cause. So you get an astigmatic post-operative result. So the vision remains 6/9, 6/6 partial in many of the cases if you use this technique. Nucleus rotation and removal of the nucleus is the same. So this technique can be used by all of us. And if you have post-operative astigmatism residual, then you can correct it by giving more limbal relaxing incisions. That can also be done. This is a technique which is done by Professor KPS Malik, and I have always followed him. And you can see here at this point, if you look at this point, your incision has been made and a vertical cut is given here and the other vertical cut on this side. So you give this two vertical cuts on the ends of the frown that you have made, and this holds the bridge tight so that the wound does not sag and the astigmatism caused because of that is prevented. So you continue with the surgery as usual, and this trick can also give you quite a less astigmatism, which is very, very important. Then iris hooks, Professor S.P. Singh has already shown wonderful techniques. I don't need to. Then this is another thing that you can do. Viscoaspiration, as you do in phacoemulsification, they say that we implant the lens under the fluid, and we take the visco from behind the IOL, which is so very important to do. So we simply go through the Simcoe in this and just shift the IOL a little bit and go behind the lens, and you will simply remove you see, just in this way you can remove the visco material, whatever is there, whatever dirt is there, whatever is debris is left there, you can remove this through main port and side ports, and you can get a very good clear media the next day. So this can be tried. Cortical cleaning is Dr. Shama, I have seen that in all cases she used to make this side port. I many a times out of hurry I not used to make it, but it is a wonderful thing, and your chamber remains quite deep when you are aspirating the cortical matter, and this can be used for the subincisional cortical matter, which is very, very good to do, and you can do the cortical cleaning through the side port and from the subincisional area also very easily. So this technique you can adopt in your day-to-day technique, and you will get better results. Sometimes we may get, as I was discussing about implantation under fluid. So you can see I am using Simcoe, not the AC Ventera in this case. And for implanting the IOL, you see this under the fluid, this IOL is held, haptics are held, and then you simply go inside, and you can see the chamber remains watertight. Almost a little bit of leakage is there, but that you can prevent. The moment the wound closes, the chamber becomes deep, and this way you can implant the lens, and you don't need too much of cortical cleaning or viscoaspiration post immediately intraoperative. So this can be used by all of us. And this is another chevron incision, as you know, जो आर्मी वाले लगाए रहते हैं इधर, उसको chevron कहते हैं. This can be used by us. This kind of V-shaped incision is given, and this causes the least astigmatism that can be utilized in your routine surgeries, which will cause less astigmatism, and the patient will get 6/6 vision as he gets in phacoemulsification. So this can be done, and this is an hybrid phaco in which manual breaking of the nucleus is there. So after doing capsular access, making side ports, taking the nucleus out of the bag, just a little bit, just a lift, which Dr. K.K. Mehta calls it as a lens salute. So you just remove it and make it a little vertical, and with the help of two SINGH, you can simply chop it. There is a chopper in one hand, on the other there is a dialer, and just stabilize the nucleus, and you can easily break it into two, and then you can use the phacoemulsification, and you can break it into further smaller pieces if you want to, and you can do posterior capsular access. Sometimes can be done by you. You can see there is a thick plaque in the posterior capsule, and this can be done by simply doing a good capsular access. It's very easy, you can try it, and this also helps. You can see there is a small posterior capsular access and you can implant the lens without disturbing the vitreous there. So these are some of the things that we can apply in our day-to-day practice, and a good biometry is of course essential for getting good result. Thank you.
Thank you, Dr. Kamaljeet Singh, for such a excellent talk and small tips and modifications you have made. Then definitely will be very much useful to everybody, and making ultimately a very good success of the container and providing a 6 vision and controlling the astigmatism.